My name is Debbie Harvey, and I'm going to run through the QOF requirements for 21-22. So QOF is worth 635 points in total, 61 of which, around 10%, are for cancer. Looking at QOF itself, practices still need to maintain a cancer register. Cancer care reviews are still required. And in addition, the percentage of patients with cancer diagnosed within the preceding 12 months who've had the opportunity for a discussion and been informed of the support available from primary care within 3 months of diagnosis is an addition. Cervical screening remains as described. Early diagnosis is a key element of the quality improvement domain. So the contractor has to demonstrate continuous quality improvement activity focused on early diagnosis of cancer. And the contractor also has to participate in network activity to regularly share and discuss learning from quality improvement activity focused on early cancer diagnosis. And they specify that this is a minimum of 2 peer review meetings. In total, the quality improvement domain is worth 37 points. So if we look at a brief summary of QOF QI, it's repeated from last year with slight modifications to account for the impact of the pandemic. What's really important is that practices are expected to undertake activity in both screening and early diagnosis. And the quality improvement activity will support existing efforts from local public health commissioning teams and cancer alliances, and will also contribute to the success of the STP or HCP and the NHS long-term plan commitments. So what's the rationale for this QI activity? The first is that although we are making improvements in the UK, we still have a way to go. The next point is that the NHS long-term plan sets out the ambition that by 2028, the proportion of those diagnosed at stages 1 and 2 will increase from 50% to 75%, and this will improve survival. We know too that the pandemic led to a significant reduction in 2-week referrals. Now, these have recovered in a number of tumour pathways, not so for lung and urology. And so there is currently a sense of vigilance in identifying possible cases so that those particular patients can be investigated and treated as soon as possible. The next point is that practitioners need to retain a high index of suspicion to continue to refer patients in line with the NICE guidelines, NG12, to safety net patients with suspected cancer, and they should also maintain an awareness of referral and testing pathways, including the impact of any pathway changes that may have happened during the pandemic. The next area is that it's important that practices continue to lead efforts to grow public confidence in the safety and availability of general practice services, including the availability of face-to-face consultations where required. And the final point is that actions taken in general practice can increase the uptake of national cancer screening programmes, including breast and bowel, and we know that these programmes have made a significant difference in the outcomes of cancer. So the overarching objective of this QI module is to contribute to improvements in relation to participation in the national breast, cervical and bowel cancer detection, prevention screening programmes among a practice's registered population, and referral practices for patients suspected of having cancer, including use of guidelines, professional development, safety netting of those referred on a suspected cancer pathway, and shortening of diagnostic intervals. Looking at quality improvement, there are basically 5 steps that practices need to undertake. Step 1 is evaluating the current uptake of screening programs in your population and assessing how well the practice currently diagnoses cases of cancer at the earliest possible stage. The other part of the step 1 is evaluating the current referral practices for patients suspected of having cancer, including assessments made through remote consultations, the use of guidelines, safety netting, and shortening the time to diagnosis. Step 2 is then about creating an improvement plan. Step 3, implementing the improvement plan. Step 4 is participating in a minimum of 2 local GP primary care network peer review meetings. And the final part of this is completing the QI monitoring template at the end of the year. So looking at step 1, identifying areas for improvement in screening. So an assessment of practice screening programme uptake rates compared to local or national baselines is really important. Public Health Fingertips has an easy to use tool to compare cancer indicators by practice, and that will help identify areas where more in-depth audits may be required. Practices should consider how they can include a focus on inequalities in screening in this assessment, particularly for those populations who are at risk and with low uptake. So the next part of step 1 is an assessment of the current referral practice. So this can be used if practices have participated in the National Cancer Diagnosis Audit, or through audit, the practices may then find it helpful to look at in-depth learning and significant event analysis around specific cases where the referral or diagnosis process could have been better. Or the other suggestion in the QOF description is that practices can look at safety netting processes in-house. So looking at identifying areas for improvement, the QI activity should dovetail with local and wider cancer activities, aligning with public health and cancer alliances. The GP network peer group meetings will provide a forum to establish and agree on allied priorities. Practices are also encouraged to seek the views of patients and carers where this might help. And practices may also find it useful to undertake a reflective group meeting and complete a SWOT analysis. So creating an improvement plan. Identifying areas for improvement should help focus QI activities, and it's really important to be clear about the outcomes, as these will then be used at a national level to assess the impact of the module. And some examples are given on this slide. Once practices have identified areas for improvement, they should be very clear. The QOF information describes the aims that should be SMART, so they are specific, measurable, achievable, relevant, and time-bound. We should also be looking at the measures, so these will be process measures, looking at outcomes, balancing measures, and looking at the changes and what different ways of doing things will be tested. Step 3 is implementing the plan. So plans should include the whole practice team. It's important to consider sharing with external colleagues such as public health for screening or secondary care for early diagnosis. And when implementing the plan, where possible, involve patients. Step 4 is the network peer review meetings, and there should be a minimum of 2. It's recommended that the first should take place early on in the year and the second towards the end. The meetings are important to validate and agree meaningful QI activity plans and share baseline. It's also important as a forum to identify wider system issues which may require collective response, and the meeting should enable shared learning. So there's quite significant information providing suggested discussion points. This is on page 103 of the QOF document. And step 5 is reporting and verification. So the contractor, so that's the practice, needs to complete the QI monitoring template and declare that a minimum of 2 peer review meetings have been attended.